So the first thing to say is, well, welcome to everybody. Also, I'm going to mention our friends from the British Heart Foundation at the back. You'll hopefully get to meet them, have a chat to them. We've got Carl, Ben, and it's Sophie at the back. Is it Sophie or Sophia? Sophie. And also Claire, who's hiding somewhere on one of the back tables from the NIHR. Because they are our financial support, and without them we can't do the things that we do, and that's why I put their logos out on the front. But the first thing I wanted to do was just say welcome to Leicester, because most of you come from outside Leicester. And in case in the rain and the mist you missed the highlights on your way in, I'll just show you a few of the highlights of Leicester. I was going to dance to the music, but I think. Executive James Dole. So that's where I hang out. So that's the Cardiovascular Research Centre in Glenfield Hospital in Leicester. So I'm not sure how well I'm doing with the microphone. I might ditch it. Can you hear me without it?
Not as well.
Not as well? Okay, I'll keep it on then. Essentially I'm an academic, so I live in one of these. Although actually Leicester doesn't have very many ivory towers, so I live in a large concrete one instead. So I guess the question is as an academic in an ivory tower, how do I end up down talking with the populace? Feels a bit nerve-wracking. Well, the answer is it's all down to people in this room. So this is a little grouping from a few years ago. Some of you will recognise yourselves. And what essentially happened with this whole world of developing research and developing an understanding of SCAD is that some of you banded together, cornered me in my ivory tower, and said, look, you wrote a short article on spontaneous coronary artery dissection a few years ago, but there's really nothing else that's happened since then in this area. And I was forced to act. And so there's a big thank you due to all of those people who came and essentially said, look, we want something in the UK to enable us to progress our understanding of this condition. So the ivory tower has crumbled, or the concrete tower, depending on. So what are we about? Well, clearly as an academic I'm interested in research, I'm interested in the why questions, but I think I like to say that we've always got these three things in our minds. Research is important. We need to understand what SCAD is, why it happens, and we need to start to understand whether we can prevent it, and once it's happened, what we do to treat it best going forward. So there are lots of questions about SCAD and the world of research, which is crucial. But I think what you can see also in this room is that the SCAD program is bigger than that, really. This is also about trying to provide support to people who have this condition. Many of you will have had the experience of going into hospital, having a heart attack, sitting on a coronary care unit and looking around you and feeling that you are the odd one out. Everybody else in this room is some years older than you are, and a very different type of person. And I think it is enormously helpful, I think, for people to realise that there are other people out there who have this condition. Karen just brilliantly demonstrated the fact that there is, there's plenty of fulfilled life after SCAD, and many people that have lived with the condition for many, 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 many years. And the final final thing, again from a kind of doctor's perspective, is that unfortunately some of you, I hope not too many, but some of you will have also had the experience where you have gone into hospital with this condition and you've been met with a sea of largely blank faces. And you found that the people in hospital haven't necessarily particularly heard of this condition. And sometimes, unfortunately, that's led to delays in terms of initiating emergency treatment. And so again, one of the important things that we want to do and we try to do is to get out there and to talk to people like me who are frontline cardiologists, but also other frontline medical professionals who might see this condition. So the obstetricians, for example, in those postpartum cases, people in the accident and emergency department who need to just be made aware of the fact that because you're young and female doesn't mean that you should just be turned straight back home again if you present with symptoms which sound like a heart attack. So it's very much a sort of a three-pronged process. So I'm going to just go through a series of questions that people ask me when they come up to see us in the clinic, and try to at least start to answer them. I know that we've got a question and answer session later on, so you can nobble me when I sort of do a sort of politician's flanneling exercise around the things where there's uncertainty. And I'm going to try and address and answer some of these questions. And just the other thing to say on the side of that, and we're trying to get the message out. Obviously, again, we have research aims, and we want to try and understand the condition, but we are learning from seeing more and more patients with this condition. And we try and get, again, the message out there that I have an NHS clinic every week. And if people want to come and see me in my NHS clinic, if you're a GP or if you meet someone online who might want to do that, if their GP writes a letter to me, I'm always happy to see and just talk about non-research things, talk about the medical things and what it's like to have SCAD, and just go through things with anybody who wants to take that approach. So what is SCAD? Well, we all know what it stands for, but the process that causes SCAD is essentially a build-up of blood in the wall of a coronary artery. So you have coronary arteries, you have these tubes around the heart that take blood to the heart muscle. Without those tubes, the muscle can't work. Any muscle needs a blood supply, and the heart is no exception. What happens in spontaneous coronary artery dissection is that you have a bleed that occurs in the wall of that tubing, okay? And that, if you like, it's a bit like a bruise. If you've had a bruise, you sometimes feel that that's sort of quite tense and under pressure and a bit sore. And that's the same thing that's happening on a small scale in the coronary artery. There's a build-up of blood, and that build-up of blood develops a pressure within it. And that pressure compresses the coronary artery itself from the outside. So the blood, which used to just flow along this tube to the heart muscle, has to get past this obstruction which is caused by the external compression. So if you look at this picture down at the bottom here, this is actually taken using a laser imaging catheter from the inside of a coronary artery. It's called OCT, or optical coherence tomography. I'll test you on that later on. And what it's showing is the things that look artificial, like the circles in the middle here, that's the catheter tube that's doing the imaging. And this bright thing here is the little coronary guide wire that's being used to take in it, and it casts a shadow because it is done with light. But the real parts about this is the coronary artery, this circle around here. And what you can see, if you like, is that that coronary artery is being squashed from the outside. It's being compressed from the outside by this black area here, which is labelled FL for false lumen. This black area is the build-up of blood outside the coronary artery due to the spontaneous dissection. The pressure builds up in this black area here, and it's pressing in from the outside and restricting the blood flow. And you get this very typical appearance. I sometimes describe it as looking a bit like a rat's tail, where the coronary artery, you can just see it's being pressed from the outside, and at this point here, the pressure is so great that it's almost completely obstructing the blood flow down the heart's artery. And so this is what causes a spontaneous coronary artery dissection. So one of the issues with SCAD, if you like, is the dissection word. And this causes doctors a lot of trouble in terms of trying to make this diagnosis, that we as cardiologists are used to dissections which we either cause during coronary artery procedures or sometimes dissections in bigger blood vessels like the aorta, which is the main artery that supplies the whole body. When you get these type of dissections, you get a big and very obvious tear. People call it the dissection flap, that you can see within the blood flow of the tube. But if I go back a slide, I think I should be able to do this with this, but anyway, I'll keep walking up and down. If you look at this, you can't really see two tubes here. You just see this tapering from the outside. And that is because with spontaneous coronary artery dissection, you don't always clearly see the dissection flap as such. And indeed, when we do imaging from the inside, you don't always see a very clear connection. Sometimes you do. So here's the false lumen that we described there, again with the imaging catheter within it. And you can see that there's literally a fenestration, a little gap, to the false lumen on the outside here. So that there is a connection between the two. But often you don't see that, or if you do see that, it certainly isn't as obvious unless you are using these very sophisticated imaging techniques to be able to look at it. And it may be that the process of dissection in a coronary artery is a bit different, and actually what happens is that the primary event is a bleed in the vessel wall, rather than the development of a communication between the, if you like, the true lumen and the false lumen. We don't know all of the answers to this, but the reason that this is important is it's important for doctors who do angiograms not to say that because I can't see a flap, this isn't a spontaneous coronary artery dissection. We'll come on to a little bit more about that later on if we don't get blown down by that gale in the meantime. So, how do doctors, people like me, know what is and what isn't a SCAD? And we've already alluded to the fact that, unfortunately, it's not an easy diagnosis to make, to be fair to the doctors. It's a rare thing. They're looking for common things. That's what we're all trained to do. So how do we work out what is a spontaneous coronary artery dissection, what is not? And I was having a bit of a chat with some of the red t-shirted ones at the back of the room earlier on about this. And I think the truth of this matter is that there's probably quite a lot of people who are just like you out there in the UK, who have had SCAD events and who don't know about it. And I think that's because this condition is often missed. So patients will come in, they'll be treated just as if they've had a normal heart attack, when actually the problem that caused it was probably SCAD. So how do we do it? Many of you will have had these experiences, but I'm just going to go through it because it helps a little bit to understand the process, if you like. Because one or two of you may have had to go back into hospital on one occasion or more, and you'll be starting to get familiar with the processes. But it helps to understand what the doctors are doing, what their process is, what their thinking is. So many of you will have had an ECG. Even I've had an ECG. It's quite scary. And the doctors are looking for patterns on the ECG. And sometimes those patterns are very obvious. I'm not going to go through the details. But this is a kind of a typical ECG for someone who's having a heart attack. And what we're really looking for is an abnormality in this area here, where there's a big step up, which we call ST elevation. Now, I'm a big fan of the ECG, and I helped to write a bit of a book about it as well. But one of the problems with the ECG is that it's great when it shows you the answer, but it's not so great when it doesn't. And it doesn't always. So the problem is that you can be having a problem with your heart and still have a normal ECG. So it helps, but not always. And that's where doctors need to keep thinking about what's going on. So some of you will have had some of these tests. So a cardiac ultrasound, that's where you have the jelly put on your chest. Anybody had one of those? Yeah, a few nods out there. And they're looking to see how that heart pumps and whether there's an abnormality in the way that the heart pumps to suggest that the blood supply is not so good. Anybody had a troponin? Most of you know nods out there. So again, troponin, just so that you understand what it is, it's an enzyme, it's a chemical. that only exists in heart muscle. And so if it leaks into the blood, then it's, again, it's not an absolutely firm diagnosis, but it makes us think maybe this is a primary heart problem. So if you go into hospital with chest pains, you should, at minimum, have an ECG done and have a series of troponins checked over the course of time to look at things. Many of you will have had other tests, and that's because spontaneous coronary artery dissection is relatively unusual compared to other causes of chest pain. And the one that people worry about is pulmonary embolus, which is where you get a clot forming in the leg veins, which then goes up into the lungs and causes problems. And so some of you may have had a CT scan to exclude a pulmonary embolus. And again, it's just because the doctors are going through their differential diagnosis list, starting with the things that they think are most likely. And because SCAD's often down here on the radar, if it's there at all, you'll go through these other processes. And then ultimately you come to have a coronary angiogram, which again will be familiar territory to many of you. So, let me see if I can just play this. And I think, again, just in terms of what the doctors are looking at when they have when they play a coronary angiogram or when they take a coronary angiogram, what you can see here is that up here at the top is a little tube. They're pre-shaped tubes, we call them catheters. They'll often be passed up from your wrist or from the top of your leg into an artery, and then they'll travel up to the heart, and what they do is they inject an X-ray contrast, so it's something that looks black on X-rays, basically. And what that then does is it lights up the coronary arteries. But what you have to remember is what it's lighting up is not the whole blood vessel with the vessel wall. Now that would be useful because then we would be able to see what's happening in the vessel wall. But what it's actually doing is it's making what we call a luminogram. It's just looking at the inside of the vessel. So it's not telling you what's happening in the vessel wall, where in SCAD we've already described you've got a blood pooling or a bruise developing. Unless that contrast can get into that area, it doesn't necessarily show it up. So all it shows is where that contrast can get to. So if you've got a complete blockage because of the compression from the outside, it will only just show you that the artery just comes to an end and stops. Okay? If there's no connection between the true lumen and the false lumen, I'm going to test you on all of this nomenclature at the end, so I hope you're paying attention. If there's no connection, as I described, between those two areas, then the X-ray contrast will not get in. And this is one of the challenges with making this diagnosis. So if you can pass one of these very clever imaging catheters down and take some pictures, then that's the easiest way. And I know that there are some of you in this room for whom the diagnosis was made using that. But otherwise, like a lot of things in medicine, this is about pattern recognition. So what's different here? I'm going to try and play this and pause it so that I can show you a little bit about how we make these decisions. So, oops, pause. There we go. So, the thing that starts, or should start to ring bells for the doctors when they're looking at this, is that this patient's coronary arteries, these black lines, to the trained eye, they're normal. They're all normal. They're totally smooth. There's nothing else going on in the arteries of this patient. Except in this artery, where you can see that it tapers off again, and then at the end here there's very poor flow going through from the outside. Now the pattern again is different. So if you're going to have atherosclerotic coronary artery disease, often it's up here in the more proximal and mid vessels. So it's just different. It's a subtle thing, but it is just different. So again, it comes back to Richard III. If it looks different, it probably is different. And that's the important message that I try to get over when I'm talking to people about SCAD. I'm not going to go into too much of the angiograms because I'm hoping that you won't have to do one. So sometimes it's a bit more obvious. Again, smooth artery, except down here. Do you see how there's a little hold up of the dye in this area, just down here? If you've got really good eyes, you might just see something that looks a little bit like a line. And so in this case, there is a little communication between the false lumen and the true lumen. The contrast is getting into it and it's just holding up. But the rest of these arteries are completely normal. So it's an unusual place to have a problem in a coronary artery. It'll be an unusual patient compared to my standard patient population. And sometimes there are particular features, the little rat's tail, or the little hold up of dye like this, which makes you think, as a doctor, that there might be a problem here. And at the end here, you can just see the pumping chamber of the heart. What you can see is just the area of injury on the heart, and we'll come a little bit onto that in a minute. So, unfortunately, as many of you know, spontaneous coronary artery dissection may cause a heart attack. And what happens in terms of the heart attack, the size of the heart attack, or the damage that's done, is very variable. Okay? And it's important to understand that because it does have an impact upon the treatment that's best for you. And so that's one of the most important questions to ask, and indeed it's when people are coming up to see us in the clinic, it's one of the things, one of the pieces of information that we try to get at an early stage. A heart attack happens essentially because there's not enough blood getting to the heart muscle to keep it alive. It's as simple as that. The heart's a muscle, it needs a regular blood supply. If that blood supply is cut off, then over a relatively short period of time, those heart muscle cells will die off. So it can happen either because the artery is completely blocked off, so there's no flow at all. Sometimes if it's very, like in the case I was just going through a few minutes ago, there's a little bit of blood seeping through, but it's just not enough to keep that heart muscle alive. And then there's sometimes a special problem, which I might be able to show a picture of in a minute or two, where because of this collection of blood in the vessel wall, it actually prunes off branches. Actually, it starts to sort of knock off branches that are coming off because it's just squeezing the branches that are coming from the side of the artery. So there are a number of reasons why this can happen. So I think, there are a few things to say about this. I think I've said already that it's an important message that the amount of heart damage that there is, or the pumping function of the heart, is an important factor in determining what the best treatment is. The amount of damage to the heart obviously depends on the vessel that's affected. Some of you will have had events or SCAD events that occurred in a little branch vessel a long way down in the heart. And that artery, because there are lots of other arteries that are supplying the heart muscle okay, the area of injury will be small. Some of you, unfortunately, may have had events that affected the arterial tree much more towards the top end, where the area that's affected is bigger. Importantly, the timing and the nature of treatment is crucial to the amount of injury. We'll come a little bit onto the treatment, and the treatment is to some extent guided, or the treatments that you've had would have been guided by what the doctors think about the situation, how much blood is flowing down the artery, and what they feel that they have to do to try to restore the blood supply. But it is crucial in terms of the education of doctors, paramedical staff, nursing staff, A&E staff, that we get a message out that this is a condition that needs to be treated quickly, as with all heart-type conditions. I think there's also a message that we are trying to get out, that in terms of treatment, to some extent, the less that you do, or the less that you have to do, the better in terms of the amount of injury. And that's a difficult one because it's a judgment. But if you can do less in terms of a replumbing job, that's often better. But sometimes your hand is forced, of course. So another question that's asked when people come and see me in the clinic, it's a very obvious question to ask, which is why me? Why did I have a SCAD event? Why did it happen to me, whereas it's not happened to any of my friends? I don't know anybody else who's had it, we do now. But why? Well, this is obviously something that we are learning more about, but we have a journey to go down to get all of the information. Abby's going to talk a little bit more about the research day, and some of the things that we're starting to learn about SCAD. We know that there's an increased risk in women, and we know that there's some association with the postpartum period, which is immediately after you have a baby. So it's clear that there is a hormonal association, an association with sex hormones. We know that there are some men that have this condition. In fact, I can see a few. And it may be that the men who have this condition, that they're a bit different. There's a slightly different process or underlying pathophysiological process in men compared to women. And we obviously need to try and tease those questions out. But it's clear that there is a hormonal relationship between SCAD that contributes to a risk of SCAD. But we don't totally understand that. Clearly there's lots of other people out there who have hormones and they don't have SCAD. So we have to try to work out why it is that it's a particular group of you that are at risk. So what about the genetic side of things? Well, many of you will have read you may have heard that there's been some interest in this. I think that there are now 6 reported pairs of spontaneous coronary artery dissections in family groups. You have to remember, whenever we're talking about the data that's out there, how it's derived. And I'll explain what I mean by that. You are all a fantastically motivated group. You've been motivated enough to come on a rainy day to sunny Leicester to hear me whittering on about SCAD. But what that means is that the research study populations, probably less in terms of us in the UK, but more in particularly in terms of the Mayo Clinic series that you'll be very familiar with, is particularly concentrated on people that have had a worse time or who are a bit more unusual. And that does affect the data that comes out from that particular research study. So what we know about the genetics is that there are 5 or 6 families. They are not clear-cut pedigrees, as we call it, where you have one person in the family, therefore the child definitely has it, all siblings who are female get it. They're not like that. There's one set of identical twins, there are some mother-daughter pairings, and there are some cousin pairings. Okay? But the genetic contribution, what this is telling us is it's not directly inherited in a very simple way. So this is not like Duchenne muscular dystrophy, for example, something that if your parents got it, you know, the chances are very much higher that you've got it. So there probably is, it's no surprise, there probably is some genetic associations with SCAD. And we are part of the SCAD research community in terms of us and the Mayo Clinic and the Canadians and so on. We're all very interested in trying to understand that because it will help us to try to tease out the pathophysiology, the reason why it happens. Okay? But I very much doubt we're going to find a very simple genetic answer where there is single gene X that we can test you all for, and then we can test family members for that gene. I think it's going to be more complex than that, much more complex than that. Okay? I'm happy to try and answer questions on that one a bit later on. It's a bit of a qualifier, so I'll move on. Connective tissue disorder. Is SCAD a connective tissue disorder? So connective tissue is the glue that holds you together, if you like. So it's quite important. In the terms of SCAD, what the connective tissue is doing is it's holding the layers of the blood vessel together. So the blood vessel's wall has a number of different layers, some cell layers, then it has some elastic layers that help it to be springy, and then it has some more layers of connective tissue on the outside that hold it all together. Okay? Now we know, and have known for some time, that a few patients who have known connective tissue disorders, and they're conditions like Marfan's and Ehlers-Danlos, but again I'm not going to test you on it later, so don't worry too much. But we've known that some of these patients have SCAD. There may be 1 or 2 patients in this audience who know that they have a definite connective tissue disorder and have had spontaneous coronary artery dissection. However, again, our experience is that the majority of patients who have specific genetic tests or specific clinical tests to look for known connective tissue disorders, that those results end up being negative, that it's not clear-cut. You don't fall into a nice, easy category of connective tissue disorder. But what we are finding is that there are some subgroups of patients who we're seeing in the research program who have some features of different connective tissue, shall we call it that? And that's in terms of being a bit bendier, a bit more flexible. All of those kind of measures that look at skeletal connective tissue, they're a bit different. But it's not clear that everybody has that particular type of presentation, if you like. So connective tissue is something that we're interested in. It's something that we're looking at, having all talked to you a little bit more about some of the ways that we're probing the connective tissue to try to find out how that might be involved. Exercise, that's a nice common question. Can I go back to exercise? Am I safe to return to exercise? The concern arises from the fact that, again, in the older literature, from when I had long flowing black curly hair and we started thinking about it, in the older literature, there are a few cases that are reported of spontaneous coronary artery dissections occurring during or following the extremes of exercise. Okay? Our experience from the research study so far is that, again, we do find that there are some groups of, some subgroups of patients who, when they had their event, were on the fitter end of the spectrum, if you like. So they were people who, welcome. Sorry. No, please. You've missed the dull bit, so you're fine. Come on, grab. Yeah.
Just come
through across and we'll
register you.
We'll get you some all-important caffeine so you can stay awake for the rest of my witterings. So there are a few reported cases, but our experience is that yes, people are, some people are more on the sort of higher end of the spectrum in terms of their exercise capabilities. But actually that may be telling us a different thing. So it's not saying to us that exercise causes SCAD. What it's saying to us is that perhaps the thing which causes SCAD also causes or also leads in some patients to you being, if you like, people that are better at exercise, better at sport. And this is known in the world of cardiology. So for example, you'll have seen the unfortunate Patrick Mwamba, the Arsenal footballer who collapsed on the pitch and was amazingly resuscitated by a team of people that were watching Arsenal and taken to one of the London hospitals. So you see that now and again, don't you? You see those footballers who collapse, and they often, it's not SCAD by the way, fortunately, but they often have heart muscle abnormalities, thickening of the heart muscle, which causes this problem. And you sort of think, well, how could they not know that they have this heart condition and still be a Premier League footballer? And probably what it is that the abnormality of the heart muscle that they have actually gives them a slight competitive advantage on the sports field. So it means that they're a little bit quicker, a little bit fitter, they can last a little bit longer. And again, it may be, and these are all questions, there's lots of questions still in the world of SCAD, but it may be that the reason that some SCADs, and again it's a subgroup, not all of them, so if you're sitting out there thinking this isn't me, then that's okay, because just as there will be a small number of you out there who are men, a small number of you out there who are postpartum SCADs. One of the important aspects of the research is that we're starting to be able to categorize people, starting to say, look, this is one of that group of patients who fits into that particular type of thing. So there has been a research study on cardiac rehabilitation after spontaneous coronary artery dissection, which showed that was perfectly safe. Okay? My advice on exercise is that all of the research that we know about exercise in any heart condition is that it is broadly good. Personally, because I'm a kind of conservative kind of chap with a small c, personally, I wouldn't go to the extremes of saying, let's go run a marathon, let's run up a mountainside. Personally, I would avoid the extremes, but I definitely do encourage you to continue to stay fit, stay out there, keep exercising, keep walking, gentle exercise, swimming, all of those things, My view is that they are good. Okay? You will read other things, and that's because with SCAD there are no definite answers, because we're still learning about this condition. Okay? But what I haven't seen in the research patients that we've got so far is a patient who's gone out there, had a SCAD event, and has then thought, right, I'm going to get myself back on, I'm going to get fit, and has gone to the gym and had a further event. I've never seen it. Never seen it. So I think exercise is, broadly speaking, a good thing and should be continue to be encouraged. Stress. Feeling a bit stressed myself right now. That's because the timing of a talk is always terribly difficult, and I think when I did it earlier it was 4.5 hours. So I'm trying to talk a bit faster. Stress is a difficult thing. It's a difficult thing across the piece in cardiology. We kind of all know that stress is not a great thing in the world of cardiology. It's terribly difficult to pin down exactly what it is. And it's also a rather difficult thing to avoid. I had a patient quite recently who came to see me in the clinic, and he said, he had a heart attack, not a scan, and he said to me, I work nights. He said, what should I do? And I said, well, it's tricky, because it's well known that working nights tends to be a bit more stressful on your body over the course of time. But I said to him, let's be honest about it. I work nights. Don't like it that much, but somehow people keep ringing me up and telling me to come in and sort things out. I can't really go to Jeremy Hunt, who wants me to work 25/6 or whatever it is, 25/9, and say, Jeremy, working nights is not so good for me. I think I've decided to jack it in now. You know, we have to live in the real world of what you can and cannot achieve. But if you can do things that just reduce your stress levels, keep you fit, keep you out there, I think they're all good, all to the good, and I think we'll perhaps be talking a bit about those a bit later in the day. So, what treatment did I have at the time and why? So again, I suppose I'm putting this in so that many of you will have been through a very traumatic experience, and when you have a traumatic experience, I can certainly remember some traumatic experiences in my life, mainly around the birth of my first daughter, and it's always strange as a doctor when you're on the other side of the fence, and you're trying to get answers to questions and figure things out. And one of the things that I remember is that things just go whiz straight past you. You can't really remember what was said and what did they say was going to happen next and why are they doing this. So I'm just going through it again a little bit slowly so that hopefully if some of you out there wonder what happened when you were in hospital and having this thing happening to you, can understand a little bit about the whys. So what treatment did I have at the time and why? So there are a number of ways to treat SCAD. And I alluded to this a little bit earlier. And the first way is to wait and see. Now this is an angiogram of a patient who had a SCAD event. By memory, it was about here. And when she came to hospital, she still had blood flowing in that artery. So she'd had some chest pain, she did have a rise in troponin. It was a source of anxiety for us, but she seemed to be settling down, and we were able just to be patient and let it settle. Some of you will have been in that situation yourselves. And this is called kind of a conservative approach or a medical approach. And on the whole, what we are learning as we're looking at SCADs that are being managed across the world is that if it is possible not to step in and to start using a replumbing procedure, a revascularization procedure, then that is probably better. But it can be difficult, and I know that there are some of you out there who I've spoken to before who have had long periods of time, of sometimes weeks in hospital, just trying to wait for this thing to heal. But what we do know, welcome, come and grab a pew. So what we do know is that if you leave this, it will heal. it will heal. And certainly again, from the research study where some of you have kindly come up to have your coronary arteries re-imaged, when we look at them again, generally speaking, there is no sign or evidence of what happened before. It seems to just heal of its own. Ooh, am I clicking on? Where did I go to? There we are. So that's conservative, certain weight. So stents. Again, many of you will have had stents. The scenario is usually that it's just either just not settling, or the ECG and your symptoms are continuing, and we're worried that the heart damage is progressing, and we feel we have to do something to try and sort that out. And this is a SCAD, again, just in a particular place. It just has that look of external compression, and it's a difficult thing to describe this, but if you have a really dull life like me, which you spend looking at coronary arteries, you can see this is different. It's in a different place and it looks different, and that's what I keep trying to say to my friends and colleagues around the UK. And this is what it looks like after the stent. So there's a stent from about here to about here. There are different types of stents. Few of you, I suspect, will have had something called a bare metal stent. Bare metal stent is, if you like, what we had in the original. So a stent is a wire mesh tube which just literally pins open the artery. That's what its job is. Am I still miking up okay? So
it's intermittent, there's a disconnection.
Can you hear me okay?
But we're getting everything okay.
What I might do is just ditch this and shout, because then you can definitely hear me. So bare metal stents are essentially a wire mesh tube which you can use to pin the artery open. The problem with bare metal stents is that they cause a scarring reaction inside the heart, and they can sometimes re-narrow. So for the most part, unless you had your SCAD event some years ago and you had bare metal stents, most of you who have had stents will have had drug-eluting metal stents. Okay? And the drug is there to damp down that scarring process. And what we know from stenting in the heart's arteries in general, it's a great treatment. So if you put a stent into a coronary artery, your chances of having a problem in the same place are essentially trivial, of the order of a couple of % over the course of maybe 5 years, even longer than that, as far as we know for certain stent types. Some of us in the UK, myself included, are interested in a new type of stent, which is a dissolvable or bioabsorbable stent, or scaffold. And this is a stent which dissolves away. There are some potential positives for that kind of stent going forward, and that is that we know it's gone in 3 years, and we know that the blood vessel seems to restore back to normal. Now in SCAD, where we know that the artery is essentially normal, it doesn't have these fatty deposits that the atherosclerotic coronary arteries have. It may be this type of thing is attractive in some cases, but we're learning about this. So in fact, this is a case that I did with a bioabsorbable stent. So just so that you've heard what they are. So if you go along to see your cardiologist and he says you had a drug-eluting stent or a bioabsorbable stent or a bare metal stent, you'll know what that is. So some of the challenges with stents, and this is the reason that I said a few minutes ago that what we need to try to encourage our colleagues to do if possible. So the problem with, not problem, but one of the challenges for people that do angioplasty like me, we call it the oculostenotic reflex, which means if you see something narrow, there's an sort of irrepressible urge to put a stent in it. Okay? Now that is probably, is probably mostly appropriate in the world of atherosclerotic coronary artery disease, but in SCAD, we need to try and control ourselves, if we possibly can, and manage this as conservatively as possible. And the reason is that stents can sometimes cause difficulties, and some of you out there will be in a position where you had a stenting procedure and you had several stents or lots of long stents. And the reason for that is this, which is that, it's because it's different to the standard disease. The standard disease is cholesterol-based, it's thick, gloopy stuff, and it has lots of cells associated with it. So when you put the stent up, generally speaking, it just displaces that fatty stuff and it sits there and does a good job of providing a new scaffold. Blood's different. It's squishy stuff. And when you stretch it from the inside with a stent like this, sometimes you get this phenomenon where you put the stent in, it squishes the blood out the way, but unfortunately it just squishes it up both ends and causes a new problem at the end of the stents. So then you have to put another stent in to cover that, and lo and behold, it squishes it a bit further along. And this is one of the problems with stenting SCAD. And again, one of the reasons it's so important to keep educating people who do this kind of procedure to spot it. Because if you know that you're treating SCAD, if you feel that you have to stent it, then sometimes the best thing is to take a bit bigger stent to start with to try to avoid ending up chasing your tail down the artery. And these are all just things to learn. But again, if you think to yourself, well, why did I have 4 stents? It may be that this was the problem that the operator dealt with. And again, because of these problems, we try if we can not to stent, but sometimes we have to. So some of you will have had bypass surgery. I can see a few friendly faces that I know are in this position. Again, the doctors that are looking after you will try to avoid this if they possibly can. But sometimes we end up with a number of situations. First of all, sometimes you just can't pass a wire through the SCAD. In order to be able to deliver these stents and balloons, what we do is we pass a little fine hair-like wire down the coronary artery. We then follow it along with the balloon to stretch things up before we put the stent in. If you can't get the wire into the far off part of the vessel, then we can't even start. Sometimes the wire goes into the dissection. So instead of finding the artery, it goes out through one of those holes I showed you earlier, and it goes off into the dissection flap. And again, it can just be very difficult to try and treat these things with stents in some cases. And sometimes when the SCAD involves an area of the heart called the left main stem, which is the bit right at the top. So it's right up here, where everything begins. So you can see that if you have a dissection here, all of the territory that's supplied by these arteries is in jeopardy. And sometimes when you have that situation, the doctors looking after you will weigh up the risks and benefits, and they will say, look, it's just too dangerous to sit and wait. Putting stents in that area can be particularly challenging because, again, if you get those problems that I've alluded to already, you can be in a pretty hairy place quite quickly. And sometimes the best thing to do is to stop and ask a surgeon to go round the problem and try and solve it that way. And there will be some of you who have been in that situation. One of the challenges with bypass grafting is what happens to those bypass grafts if and when the SCAD heals. And will those bypass grafts still be hanging on there, or will the fact that the blood restores in your normal heart affect how those grafts work in the long term? And we don't know the answer to that. But again, it's one of those areas where SCAD is a bit different to normal atherosclerosis. But to be honest, if you're in that situation, then sometimes that is the way to save somebody's life. And that's what you have to do. So, all of you are SCAD survivors, and so this is going to be the area of probably most questions. What now? What treatment should I be taking now? Now, as with a lot of things with SCAD, this is an area of evolving knowledge. So, speaking personally, 5 years ago, I had some knowledge of the condition in terms of the limited literature that was available. Nowadays, we probably see, Abby and I probably see 2 or 3 of you in the clinic, my NHS clinic, on a Friday afternoon every week. And we're starting to get just a bit of experience of what works. It's not the same as a randomized trial where you can say, well, we've got the comparative evidence. But again, the more of you and the more people out there who register and support the research, some of those kind of clinical research studies will start to become possible, because we can start to say, well, what happens if we treat one group in this way and the other in that way? Are they the same or are they different? And start to really learn about this. So which medication? I'm going to try and answer these questions, but they are questions that you all ask, so I'm keen to try and do it as much as possible. So what about the antiplatelet treatment? Some of these are going to be familiar for you. Aspirin, clopidogrel, ticagrelor and prasugrel. The answer is quite easy, to start with at least, if you've had a stent. Generally speaking with stents, because the stent itself is a bit sticky, particularly the ones with the drug coating I mentioned earlier, you do have to take the antiplatelet treatments, and usually you'll take 2, aspirin and one of the others that I've listed up there, for a year, and then you will continue to take one after that. Now there are questions about the very long term with these type of treatments. So we know that the drug-eluting stents will eventually be incorporated into the wall of the coronary artery, such that if you were flying down the artery from the inside, rather like those laser imaging probes, you wouldn't be able to see the stent at all. But I think at the moment, the evidence would suggest that if you've had a stent, that you should be taking one of those drugs, probably aspirin, going forward. Okay? Because of the risk, and we know that there is a risk that the stents can clot off even quite a long time after you've had the stent put in. So I would have to be persuaded quite strongly by someone to say that they were really struggling to take the chance of stopping all of the antiplatelet treatments. Likewise, if you've had a bypass operation, usually as part of that bypass operation you will have had veins that have been taken from the legs to provide the conduit to go round the SCAD. Okay? We know that those veins are, they're designed to take the blood away from your leg. They're not designed primarily by the biological designer to be taking blood to the heart muscle. And so they're a little bit baggier. They might have little valves in them, things like that. And so again, my recommendation would be that for those of you that have had bypass surgery, that you should continue to take one antiplatelet therapy treatment into the medium and long term. The hard area is for those of you that have had conservatively managed SCAD, where you've had no stents and no bypass surgery. And I think this is an unknown. Okay? I think it can be harder if you've got an area of injury on your heart. We know that the heart pumps a bit more weakly, then I might be a bit more anxious about blood clotting in the heart itself and want to have a blood thinner on board. But if you've got relatively normal heart function, your coronary arteries have essentially gone back to what they were before, and you've had no stents and no bypass surgery, I think it's a major question mark as to whether you should have antiplatelet treatment and for how long. I mean, there are lots of paradoxes in this which you can probably feel for yourself, which is that the problem here was a bleed. It wasn't a clot. The primary event was a bleed in the vessel wall. And so it feels a bit strange to be giving things that thin the blood. But we just don't know the answers to these questions. And certainly what we don't see, if you like, is that the antiplatelet treatments that you give after stenting, we don't seem to see people having problems in that first year when you're on dual antiplatelet therapy after stents. So it doesn't suggest to me that it's particularly unsafe. But I think in the conservatively managed group, it's a question still in my mind.
Is there a consensus emerging around that? Because I'm sorry to speak personally, but I'm not consensus on I'm just interested about that.
So I mean, I think there isn't a consensus, and I think what many of you will find, and part of the reason for going through this in this way, almost like drug by drug, if you like, is that what tends to happen is that you, right from the get-go, you're treated just the same as the next heart attack patient. And of course, we know that this is a different process, it's a different problem. And it may be that the automatic response to do exactly what you do in those patients isn't the right one. But we don't know the answer to that question. But personally, it's an area that certainly if you were to have problems with taking aspirin causing other issues, indigestion, bleeding issues or problems, I would feel more relaxed about stopping it. But I think the other message which is important is that I suspect that this kind of discussion will emerge onto the internet forum. And I think it's very important to remember that probably the question mark predominantly applies to that scenario. Conservatively managed patients, no stents, no bypass grafts, and a good pumping function. So don't sort of, if there's a sort of trend on the internet to say pack in your antiplatelet therapies, remember that probably doesn't apply to you if you've got stents in particular. So I think it's, I don't think it's as far as a consensus, it's a question mark. Beta blockers. Beta blockers end in lol, so bisoprolol, carvedilol, atenolol. Again, they're very standard treatments after heart attack. I think the first and most important thing to say about the next two groups of drugs, the beta blockers and the ACE inhibitors, what we do know about these drugs is that they are important in patients who have damaged hearts. So if the heart has an injury on it, if your pumping function of your heart has been damaged by the SCAD that you have, then these are drugs that I would favour. And the reason is that what we know about these drugs is that for heart failure or heart damage, regardless of the cause of that heart damage, so for example, anti-cancer treatments can sometimes cause the heart's pumping to weaken. And these drugs work in that scenario too. So whatever causes the damage, these types of drugs seem to be beneficial. So again, it's probably not one size fits all. If you have impaired pumping function, I'm going to be inclined to get you on a beta blocker if you can manage it. Okay? The problem with beta blockers, and there'll be some of you out there for which this is a familiar story, is that we find that lots of SCAD patients, not all, but some of you, get a lot of chest pain after the event. So you have your index event, but then afterwards you continue to get these episodes of not quite as bad as when you came in, but sometimes pretty nasty chest pain. We don't entirely know why that is, but we wonder whether it's because you have relatively reactive arteries. So when you're young, your arteries just tend to be a bit more reactive. They tend to have the ability to squeeze down or dilate up. And it may be that people with SCAD arteries are particularly able to do that squeeze down, stretch up thing. And I think that sometimes the problem is that these coronary arteries can go into a spasm event. And we've seen that in some of you who have had stents. That I've certainly seen some pictures where somebody's had a stent for a SCAD, and then they've come back some months later with chest pain, and you can see the stent looks beautiful, and on each side of it, the artery is just squeezing down. It's gone into a sort of spasm response to the stent. And I think that kind of explanation may be a common reason for people having chest pain. Now the challenge with beta blockers, the LOLs, is that in some people, we know from other conditions where coronary spasm is relevant, that they can make it worse. So if you have a normal heart pump and not a big injury on your heart, but you're getting lots of chest pain, you will often find that I'm inclined to take away the beta blocker and replace it with something that causes the vessel to dilate. And there are a range of different treatments that do that. We often try to use something called diltiazem,
that there are a range of different vasodilators. And the idea behind that is beta blockers can sometimes make spasm worse. We'll try to use things that dilate the artery in the hope that that will help your symptoms. And again, this is not based on big trials. This is based on you coming to see me in the clinic, having people that have gone through this process, try it out. It seems to work in some of the patients who have had these problems, and that's the reason that we're trying to, roll it out to other people that are in a similar situation. So ACE inhibitors, those tablets that end in pril, and there are a related group of drugs called that end in sartan. So ramipril, captopril, enalapril, low-sartan, candesartan. These are these type of drugs. The sartans get used for people that are intolerant of ACE inhibitors, usually because of dry cough. So there'll probably be one or two of you out there that got started on an ACE inhibitor in hospital and then spent a period of time hacking away at home going, this really tickly cough that I've got, I can't get rid of it. And hopefully that was picked up and you were changed onto a sartan, or angiotensin receptor antagonist. They do a similar biological thing. Okay? They're similar types of drugs. Again, the ACE inhibitor groups, or the angiotensin receptor antagonist groups, we know are very good for people that have damaged hearts. So whatever the cause, and SCAD is obviously one cause, if you have an injury on the heart muscle so that the heart doesn't pump as well as before, these are good things and they've been well studied in damaged hearts from a whole range of causes. So I tend to want to keep patients on these type of drugs, particularly if there's an area of injury on the heart. That's the primary motivation. So if you've got impaired function, I want you to be on a beta blocker, I want you to be on an ACE inhibitor if you can possibly manage it. Statins. I'm sure you've all read everything on the internet about statins and the 5,000 pages of the Daily Express on the subject as well. I mean, there's a lot written about statins. Let's just give my particular insight, if you like. SCAD is not a cholesterol-mediated condition, unlike atherosclerosis, which is the slightly wordy other condition which causes the heart attacks. The build-up of cholesterol, the build-up of fat, you've all seen the sort of pictures and read about it. SCAD is not caused by cholesterol. So it makes me much more reluctant to go down the route of treating people with statins. Now there are some caveats, and I'm going to mention those caveats because, like a lot of things in SCAD, it's not yes, no, it's not easy answers to things. My view is, if you had conservatively managed SCAD, it's not caused by cholesterol, there is no reason for you to be taking a statin. Okay? That it gets harder if you've been treated with stents or bypass surgery. Let me explain why. Bypass grafts, let's deal with that end. We know that particularly the grafts that come from the veins have a higher propensity to develop that atherosclerotic process. Okay? So it tends to happen a bit quicker in a bypass graft to that in a normal vessel. So for me, if you've got bypass grafts, my threshold for statins is a bit lower. Okay? It's difficult to be certain, but I know from the other populations of patients who have had bypass grafts, now, of course, those people have got atherosclerosis already. So it's a difficult jump, but I know that bypass graft-related disease is accelerated in that population. And so my inclination would be, if you've got bypass grafts, that you probably should be taking a statin if you can manage it. Okay? Stents. Even harder. We are finding in stents in patients who have atherosclerosis that over a long period of time, many, many years, a small proportion of patients come back with atherosclerosis-like problems inside the previous stented segment. It's incredibly difficult to take a leap and say what that means in the world of SCAD. My inclination at the moment is to say that in SCAD patients who've had stents, there probably is not a strong indication to have to have statins, even if you have stents. But I think we're going to keep a little bit of an eye on this thing called neoatherosclerosis that's being reported in patients who've had drug-eluting stents for many, many years, and just see what that might mean in the long term in terms of statin treatments for patients who have stents. It's a big jump, because we don't really know that statins have an effect on that particular problem. We don't really know whether that particular problem arises in patients who've had a stent for SCAD as opposed to having pre-existing cholesterol and atherosclerotic related disease. So for me, and this is a judgment, you were saying it's a consensus, this is my view. If I had a bypass for my SCAD, I would take a statin if I could. If I had conservatively managed SCAD, I wouldn't take a statin. If I had stents, at the moment, I wouldn't take a statin, but I would keep my eye on things, but I wouldn't take a statin right now. And just a few other things. We mentioned the vasodilators already. The other thing is the mineralocorticoid receptor antagonist. They try to make the names of these drugs as difficult and tongue-twisty as possible so that you can't possibly say them. So those are things like spironolactone and eplerenone. Those are drugs which are generally used for people who have more damage and have heart failure. So again, I just put it in there because some of you may be taking them and thinking, well, hang on a second, he hasn't mentioned that. And again, they are, like the ACE inhibitors, beta blockers, they are good if you've got a scar on the heart and a problem with the pumping function. So that covers the drugs. Now, I'm absolutely happy to take lots of questions later on drugs, because this is, something that's relevant to everybody. And, there's not always right and wrong answers, but I can at least try and give a view. So particular issues in SCAD survivors that are worth just raising and mentioning. Menorrhagia, heavy periods. Of course, the world of cardiology is all orientated around guys, and mostly the women that get atherosclerotic coronary disease are postmenopausal. So we're not used to, we just give everybody lots of blood thinners, and we're not used to the consequences that, of course, happen in menstruating women. So that can be a problem, and there are a number of potential approaches to that. Contraception is is obviously a very important thing to think about, and again a grey area, an area of uncertainty at the moment. One of the interesting things that we've found with the research side of things is that the vast majority of patients who are registered with us who've had a SCAD event have had it when they've not been taking a hormonal contraceptive. And again, we know that this is a condition that happens mostly in women and that there's probably a hormonal link. But certainly what we're not finding is that it's all people that are taking the pill. It's not all people that are taking hormonal contraception. I'm not saying it's exclusive, but it doesn't seem to be, to me, that contraception is a frequent feature in patients who have had these events. And so it's a little bit of a leap, but my view is that hormonal contraception is probably not unsafe and might be certainly beneficial in terms of people that are having problems with menorrhagia, or people that are having problems with cyclical chest pain, which is again something that we see quite commonly in that age group of menstruating women, that you're getting premenstrual chest pain. And again, we've certainly have a few people now that we've tried a mirenocoilin where that seems to have helped, just seems to have damped down the changes in the hormones and has helped with the menorrhagia and has helped with the premenstrual chest pain. Now we're learning about these things. These are small numbers of people, and we need to keep an eye on this particular ball, but that's where we are at the minute. Recurrent chest pains I've talked about. We wonder about coronary artery spasm. It certainly is a problem. And I think it's a problem that we need to get out there and say to people, this is part of the problem that you have. Because I think there's lots of people out there who have SCAD, they have this enormous life event that happens to them at a completely unexpected point in their lives, and then they're getting ongoing chest pain, and you start to think you're going crackers. But actually this is part of the condition. You're not alone if you get this problem. This is something that I see in clinic every week. It's difficult, and we're trying different things, trying the vasodilators, sometimes trying the hormonal strategies to see whether we can help you to try to get these things under control. And sometimes we have to be a bit imaginative. Sometimes we try even a little bit of maybe a gentle sedative or an antidepressant, and just to, not necessarily because we're thinking that your mood is depressed, but just to try another strategy to control the pain. And I think you have to, we're still learning about that, but it's a common problem. It's part of the thing. We'll perhaps talk a little bit about this at the end, but again, I think this is enormously important. SCAD affects everybody. It affects the cross section of society. It affects people that are kind of in the bright end of the spectrum of the high income bracket, right down to people that are struggling in life already before this happens to them. It is a terribly difficult thing when you're young and something unexpected like this happens to you to get over it and to move forward with life. Some people manage it, take it in their stride, but often it's harder. And you guys are enormously important to each other in providing some support for that process. Some people will take a lot of support from patients around them. Others find that they like to sort of step back a little bit from the patient group. But I think we have to recognise that this is something that happens to people. Do I need a defibrillator? I put this in here because it's something that there's a lot of conversations in the US about at the moment. I'll tell you my view on it. So the starting point for the American discussions, and we'll come on to this a little bit later, is the recurrence risk for SCAD. So we know that some people can have more than one SCAD event, and we'll talk about that in a few minutes' time. And they want to extrapolate that and say that because there's a recurrence risk, that you should be protected from a rhythm disturbance with a defibrillator. Okay? And I say to myself, well, the recurrence risk for somebody who comes onto my list next week having a heart attack is not trivial. But I don't put a defibrillator into everybody who comes into hospital with a heart attack because of that recurrence risk. I suspect the recurrence risk for SCAD is lower than we think, and I'll explain that a little bit in a few minutes' time. You have to remember that things like defibrillators, they are procedures, they're operations, they have risk associated with them. Once you have it put in, if the lead breaks, you have to have another lead put in, another procedure, you have to have the box changed. They carry a risk in and of themselves, particularly if you're young and you're going to have it for life. So my view on defibrillators, just when you read the sort of US type discourse on should everybody with SCAD have a defibrillator, my view is that this is a treatment that should be restricted to the small group of patients who have had large infarcts, large areas of injury on the heart, where we know there is sometimes a risk of rhythm disturbance. And there'll be one or two of you probably that fall into that group, in which case the defibrillator is perfectly appropriate and reasonable for that reason, as a kind of, a backup to get those rhythms fixed up if you need them. But I don't, at the moment, support a view that this should be a general treatment for SCAD. Okay? I think it's one of those things in the US that there's always a tendency in the States to do everything. It doesn't really matter whether you thought it through, just to throw everything that you've got at something. And I'm a bit concerned. I don't think that that's appropriate. What further tests do I need? I've had SCAD. What do I need now? Well, again, we're learning a little bit about that. Obviously, quite a lot of you are having tests done as part of the research. And it is likely that some of those tests will need to kind of roll out a little bit into the clinical arena to make sure that we've looked at these things. An assessment of coronary artery healing. If you've had it managed conservatively, should we be checking up to make sure that that artery is healed and stayed healed? I think, again, we're learning about that at the moment. We're looking to see when healing occurs. It's probably not necessarily to keep looking. So as long as it's all healed up, it's probably reasonable to leave it there and not to keep looking at the coronary arteries. Certainly, my personal view is that repeat angiography, where you take pictures of the heart's arteries, should be avoided if possible. And that's because we see the occasional case, we've seen one quite recently, where you get a catheter, goes into the heart's arteries and causes a dissection. Now that's not because the operator's rubbish, hopefully. It's because the arteries are probably fragile. The nature of the problem that you all have is such that, these are arteries that are prone to getting into trouble. So I don't like angiograms, and again, there are some centres that still will do a routine follow-up angiogram, just bring you back and have another look. I'm not keen on that, especially as we have CT, which can look at this very effectively. So at the moment what we're doing is we're looking to make sure that it looks like it's healed and that blood is flowing back down the arteries again, but we're not looking repeatedly. An assessment of heart function, I think, is really important. And the reason is that we've come to several points in these slides where I've said, this depends on what your heart pumping function's like. Should you have a beta blocker? Should you have an ACE inhibitor? Should you have a mineralocorticoid receptor? I nearly managed to get that out without tripping over it. Should you have a defibrillator? Lots of these questions, for me, relate much more to what the pumping function of your heart is like than to the SCAD event itself in a way. So I definitely think that at minimum you should be having an echo, and certainly our practice is to try and get an MRI to look at the injury, to look at how well the heart pumps, and to use that to help to guide the treatment. An assessment of the arteries elsewhere in the body. You will be aware, many of you, maybe some not, that there is an association between SCAD and abnormalities of the arteries in other areas of the body. However, those abnormalities which get quoted at very high percentages, okay, many of those abnormalities are not important clinically, so they're not going to cause you any problem. They're there. They're a manifestation of the fact that spontaneous coronary artery dissection is there's a problem that causes it, something to do with the way that the artery wall is. But it's unusual for us to find, and again from Abby's work, it's unusual for us to find patients with clinically important issues. We do find a few, but they are rare. Okay? Things like FMD, fibromuscular dysplasia, that you'll have heard of, is much more common, but its clinical importance is much less clear. So yes, there are lots of people with FMD and SCAD, but there are lots of people in the world with FMD, and we don't really know whether that matters or not. Certainly the FMD literature at the moment isn't particularly suggesting that it causes major problems in the vast majority of people. So again, my practice here is that I would like to have an assessment of the arteries in your body by an imaging process, but I don't necessarily think that if we don't identify a problem, that needs to be done repeatedly over time. So I think we just need to have a look. There'll be a small number of people for whom maybe the SCAD is part of a bigger problem that we might want to follow up for that. But the majority, it'll be a look-see, and that's all that will be required. Genetics we mentioned a little bit earlier, and this is another question that gets asked. Should my family be tested for SCAD? I've had it. What about my kids? What about my sister? Well, the first thing to say, which is an important one, is that there isn't a test for SCAD. So there isn't a genetic test because we've no associated genes at the moment. And there isn't a screening test. Nobody, if we'd taken you before you had your SCAD, taken you off, and done all of the research investigations, would we have been able to do any single test there that would have predicted what was to happen to you? Probably not. Probably not. So there isn't really a test that can be done. And furthermore, as I alluded to earlier, and I won't go back over it again in detail, yes, there will probably be genes associated with SCAD. There are genes associated with atherosclerotic coronary artery disease. There are genes associated with many conditions, with cancers and so on and so forth. But it's not going to be a primary genetic condition where the gene's the absolute thing that caused it. What it will be is there will be a small number of genes that contribute together, work together, to lead to a predisposition to make you more at risk than the next person. So it's unlikely, in my view, that there will be a genetic test that will capture the majority of people with the condition. There may be a small subgroup of patients who have a very clear genetic explanation, but probably for most of you it will be more complicated than that.
How am I doing? Am I all right still? Come to the end, says Karen. Okay. What is the risk of pregnancy is another important question. Obviously, SCAD affects young women. So this is a key question. The answer to this question is that we don't know the answer to this question. There have been a small number of pregnancies worldwide that we're aware of. We're aware of a few that we have that have gone through pregnancy and come out the other side. We are aware of one person who has had a postpartum SCAD after a first event. So there's one that's happened that we know of, and we also know of maybe of the order internationally of about 10 to a dozen people that have had successful pregnancies without issue. So because of the one, it's difficult to say that it's a risk-free undertaking because of the one. So that's what it's based on. Okay? So, that's as much of an answer as we can give at the moment. It's not a risk-free thing, but equally there are women that have been through pregnancy and come out the other side. We're very happy to talk to anybody who's contemplating planned pregnancy about it, and certainly to try and weigh up those risks together, to look at the latest data and talk about it, and to keep very closely involved with any pregnancy that happens after that. I'm going to stop wittering. Recurrence. See, I'm getting to the important bits now, though. So recurrence. I mean, again, most of you have come here because you've picked up everything on the internet and so on. You'll have had a read of this, and the numbers that are quoted for recurrence for spontaneous coronary artery dissection can be a bit terrifying, because you look at it and you think, goodness me, is it as high as that? I better not go out the front door. But what you have to remember is that these are selected patients, right? So the Mayo Clinic, what they've done is they've got patients from across the US to come to them for their research study. Now, if you had an event that was maybe a SCAD that was conservatively managed, you went home, nothing ever happened to you again, and you lived happily ever after, would you bother to go all the way up to wherever it is and go and see Sharon, Hayes and the rest of the crew? Probably not. If you had a big event, or you've had two, or your mum had something similar, you're much more likely to pick up the phone and say, hey, I'm going to take a flight and go and see Sharon and the crew in the Mayo Clinic. So what you have to realise is that this is a selected population. It's not the whole population. So when they talk about a recurrence risk of 20%, 24, whatever it is, they're talking about a selected population. My view, our experience from our group is, yes, recurrence can occur. And the advice is that you have to be sensible. If something happens to you and makes you worried, then seek advice. Of course. But it's probably not as terrifying as those numbers look. I think it's much less frequent than the published data at the moment. And I think in the coming years, as our research study hopefully continues to expand and other groups around the world, and we're all working together on this, I suspect that we'll find that those numbers are not as concerning as they immediately appear. So that was just a quick slide to say that this is about collaboration. This is about us collaborating with you, us collaborating with the dream team of funders at the back of the room, us collaborating with other people in the world who are looking at this condition. And I feel very passionate about that. We will never get to the bottom of SCAD unless everybody works together to do this. And it's absolutely crucial that we continue to work with other people in the world who are dealing with this and with our patients around the world.